HIMCA, the Health and Medical Care Archive, is sponsoring this webinar today, and we are funded by the Robert Wood Johnson Foundation. I will pop our website in the chat. We have over 300 freely available data sets to explore, and it pairs well with the data we're about to talk to today. I'd like to introduce our panelists today. We have Philippa Clark. She's a research professor in the University of Michigan's Institute for Social Research and a professor in the Department of Epidemiology. She's a social gerontologist and a social epidemiologist with over 2 decades of research on neighborhoods and health. Her areas of expertise center around the role of built and social environments for disability and cognitive function. She's the director of the National Neighborhood Data Archive, and she's the co-PI along with Grace Nopert on a new NIH-funded grant to examine the socioeconomic consequences of COVID-19 for neighborhoods. Grace Nopert was not able to be with us today, but we'll talk about her work. She's a research assistant professor in the Institute for Social Research. She's also a social epidemiologist and an infectious disease epidemiologist, and her work considers the role of neighborhood context for infectious disease risk and transmission. And our last our other panelist today is Marilyn Sienkiewicz. She's a research director at the University of Chicago Health Lab and a faculty associate at the University of Michigan's Institute for Social Research. Previously, she was the director of research and evaluation at the New York City Department of Health. She received a PhD from Columbia University and completed postdoctoral studies as a Robert Wood Johnson Health and Society Scholar. Her research focuses on the social and economic causes and consequences of health inequities. She consults with local governments and communities about health and community development. And now I'd like to turn it over to Philippa Clark. Dr. Clark.
Great, thanks everyone. Thanks for being here. We're really excited to host this webinar and tell you a little bit more about our National Neighborhood Data Archive, or NaNDA. And we're going to be talking about neighborhoods in general and how they're a social determinant of health. Just a quick outline of what we're going to be covering and acknowledgements. So NaNDA is supported by the National Institutes of Health and the National Institute on Disability, Independent Living and Rehabilitation Research. What we're going to be doing today is really giving you a quick overview in general about what we mean by social determinants of health. And then we're going to talk about why neighborhoods are a social determinant of health. I'll give you a quick overview of some of the data sources and data deposits that we have in NaNDA. And we're going to give you an example about how they can be used to understand relationships between neighborhoods and health. So I'm going to turn it over to Marilyn, who's going to talk about social determinants of health. Marilyn, when you need me to advance the next slide, just say next slide.
Thank you, Philippa, and welcome everybody. We're delighted to be talking about the social determinants of health with you today. Next slide. So the first part of the presentation is designed to help get us all on the same page by dealing with some definitions and frameworks for thinking about neighborhoods and the social determinants of health, and how research can be used to improve health and social conditions. I'll also talk about several selected social determinants of health and then hand it over to Philippa. Next slide. We'll begin by highlighting 3 key issues that set the stage for thinking about neighborhoods and the social determinants. First, you'll notice that our focus today is on structural factors, meaning societal level issues that strongly influence health outcomes such as mortality and morbidity. These factors, known as the social determinants, are beyond the control of individuals. So that's beyond the control of individuals. For example, my health is impacted by the availability of fresh fruits and vegetables in my neighborhood and whether or not I can afford to buy them. It's also influenced by whether there are sidewalks and streetlights in my neighborhood and how safe it is to walk around and exercise. Thus, these things like public infrastructure and public safety are examples of the features we think about when we consider neighborhoods as social determinants of health. Second, let's take a minute to consider what health is not. Mental and physical health conditions are not moral failings, although they have been considered so in the past. Think about mental illness, AIDS, and even cancer and how these conditions have been stigmatized. Poor health is not criminogenic. even though incarcerated populations are much more likely to have mental and physical health problems compared to the general population. And poor health should not always be medicalized. It may have more to do with neighborhood structural characteristics, which cannot be fixed with a drug or a procedure. Third, there's good news. The social determinants of health are actionable, and that's what we'll talk about in our presentation today as well. Next slide, please. There are many working definitions of the social determinants of health. The one in front of you is from the New England Journal of Medicine. It's particularly salient for our purposes because it names neighborhoods. It describes the social determinants as intangible factors like political, SES, cultural constructs, as well as place-based conditions, including accessible healthcare, education systems, environmental conditions, well-designed neighborhoods, and of course, the availability of healthful food in your neighborhood. The WHO, when they talk about social determinants, also mention the unequal distribution of power, income, goods, and services that have immediate visibility in the circumstances of people's lives. They say, they note that the unequal distribution of health damaging experiences is not a natural phenomenon, but rather it's the result of a toxic combination of poor social policies and programs, economic arrangements, and plain bad politics. Next slide, please. This slide presents an example of how the social determinants of health work to impact health. The framework you see was conceptualized by the Robert Wood Johnson Foundation for their County Health Rankings project. This framework indicates that there are a wide range of policies, programs, systems, and environmental changes that can make a difference locally in our communities. Some interventions may target individual behaviors. Other strategies try to tackle systems and structures like education and economic development, and maybe increasing neighborhood safety. RWJF points out, and this visual of theirs emphasizes that no single strategy will ensure that everybody in the community can be healthier. In fact, the intended and unintended consequences of many policies and practices in the past have further marginalized groups, such as neighborhoods of color, keeping them from the resources and supports necessary to thrive. So the SDOH, the Social Determinants of Health Framework, emphasizes that we need to prioritize health equity in our research and evaluation projects. Next slide, please. So why conduct research on the social determinants of health? How can this evidence be translated into policies and programs to improve health and social conditions and reduce health disparities? Simply put, research on the social determinants is used to communicate with a whole raft of stakeholders, including health and mental health professionals, lawyers, social workers, politicians and policymakers, funders, and the public. Research on the social determinants has been used to shape many policies and programs, from policymakers formulating Medicaid legislation, physicians and social workers creating patient treatment plans, and even lawyers arguing for favorable legal decisions for their clients. So social determinants evidence is a very effective tool on many levels. Next slide, please. In this part of the presentation, we'll shift our focus to drill down and examine several randomly selected social determinants. Let's begin by reviewing a selection of research on neighborhoods to better understand how they can impact health. How do neighborhoods get under the skin, so to speak? So Cutler and colleagues' research shows that children growing up in socioeconomically disadvantaged neighborhoods may experience stressors such as family conflict and instability arising from chronically inadequate resources. Other studies indicate that the biological wear and tear resulting from chronic exposure to these kinds of stressors, we commonly refer to that as allostatic load. This kind of stress can suppress the immune system and reduce and induce inflammation. We also know that the association between duration of child poverty and adult cognitive function appears to be partly explained by chronic childhood stress. Finally, socioeconomic position and other social factors play a role in epigenetic processes that regulate gene expression. Evidence from primate studies suggests that social status can affect the regulation of genes controlling the immune system. So what we can take away from a wide body of research on the social determinants of health is that although relationships between neighborhoods and health outcomes can travel along long, complex pathways, the relationships are strong and consistent. Next slide, please. Education as a social determinant. I'll show you a couple of statistics that speak loudly about the relationship between education and health, specifically the predictive value of education for life expectancy. First, did you know that lower education is associated with almost half the deaths among working age adults in the United States? That is an arresting statistic to me. Or did you know that low education, along with racial segregation and low social support, is a risk factor for death comparable to heart disease? Heart disease is the big killer. It's amazing to think that low education is right up there with heart disease in terms of predictability for death. Next slide, please. This figure shows the number of years people can expect to live past age 25. The x-axis shows levels of education and the y-axis shows years of life expectancy at age 25. The left-hand panel charts these two variables for men and the right-hand panel for women. The important takeaway here is that lower education is clearly associated with lower life expectancy and higher education with higher life expectancy. More evidence of the direct relationship between education and health. Next slide, please. We'll discuss next adverse childhood experiences, or ACEs as they're known, and their role as social determinants of health. The early child period is considered to be the most important developmental phase throughout the lifespan. Healthy early child development, which includes social, emotional, physical, language, cognitive domains of development, all these strongly influence mental health and a host of other health-related outcomes across the life course. Research tells us that the toxic stress response, which we just discussed, can occur when a child experiences strong, frequent, or prolonged adversity without adult support. These stressors include abuse, neglect, caregiver substance problems or mental illness, exposure to violence, or the accumulated burdens of economic hardship. However, we do know that the circumstances that produce toxic stress can be at least partially mediated by strong, well-resourced communities and neighborhoods that fill in the deficits that some children face. Next slide. This graphic from the CDC is fairly busy, but it offers a clear takeaway. It shows that preventing ACEs could have positive effects on health. For example, the prevalence of depressive disorders could be reduced by 44%, which equates to 21 million cases of depression. It also suggests, this graphic also suggests that there are strong associations between ACEs and health behaviors like smoking, as well as with unemployment and low education. Next slide, please. On to incarceration as a social determinant of health. The chart on the left-hand side of this slide shows that the prevalence of serious mental illness, which involves severe impairment, is 5 to 6 times greater in jails than in the general population. It may not be intuitive to us, but evidently there is a strong relation between incarceration and mental health. 40 years of mass incarceration has had crippling intergenerational effects on neighborhoods, some of which you can see the impacts you can see listed on the right-hand side of the slide. Next slide, please. Lastly, I want to touch briefly on healthcare because the evidence may be counterintuitive to many of us. It comes as a surprise, perhaps, that although healthcare is critical to health outcomes, research shows that it is a relatively weak determinant of health. Many other social determinants, such as economic factors, have a higher impact on population health than does healthcare. One review estimates that medical care is responsible for only 10 to 15% of preventable mortality in the United States. The RWJ framework that you saw earlier gives clinical care of 20% versus 40% for socioeconomic factors. The point is that many studies affirm the overwhelming importance of other social factors relative to the importance of healthcare. Next slide, please. Before I pass this presentation over to Philippa, I'll leave you with one last example of neighborhoods as a social determinant of health. In New Orleans, where I live, we have substantial differences across neighborhoods in health outcomes, like life expectancy. You've heard it said that how long you live depends on your zip code. That's true in many cities. To understand and address these differences, we have to consider how the social determinants vary across neighborhoods. For example, in New Orleans, flood zones. Some neighborhoods in New Orleans never flood, while others have a high probability of flooding with every storm. And again, an example is some neighborhoods in New Orleans improve public safety by hiring supplementary law enforcement officers, while other neighborhoods don't have these kinds of resources, perhaps would want to do so if they did. The point here is that neighborhood level social determinants of health, such as public infrastructure and public safety, are structural factors by which we mean they are beyond the control of the individual residents of the neighborhood. Therefore, we know that access to and control over resources are not equally distributed across and within neighborhoods in the United States. Fortunately, we have a rich set of contextual measures in the NaNDA data that can help researchers describe and quantify the neighborhood health terrain, which is what Philippa will talk about next.
Great, thanks, Marilyn. So what do we mean by a neighborhood? We use this term, but I think it's important to really think about what that means. So neighborhoods are really everything. It's where we live. It's the places that we encounter in our day-to-day lives, where we're going to school, where we work, where we play, and where we receive care. They're the places where we are born and the places where we age. There's different definitions of neighborhoods, and the spatial boundaries of a neighborhood vary on so many levels. There's no one right and single definition of a neighborhood. Many people in this research area use administrative boundaries, neighborhood administrative boundaries like the county or the census tract or the block group to identify a neighborhood spatial area. Others are using healthcare service areas like hospital or primary care service areas. School districts capture the areas that schools intake their students from. When we're dealing with survey data or cohort data, we often want to find out the neighborhoods where our participants are living, where our survey participants are living. So sometimes we use their address to identify their census tract, but we can also create person-specific neighborhoods based on a half mile or 1 mile radial buffer around their location. So it becomes not only a more specific neighborhood size, but it's specific to that particular individual as well. And then you can capture the different characteristics in that particular buffer. Sometimes, the best measure of a neighborhood is what people themselves define as their neighborhood. We have a study that we use data from which asks participants directly, how many blocks are in your neighborhood? And we get a range from 4 to 100. People have very different opinions about what they think about as their neighborhood. Some people try to actually measure that by outfitting participants with GPS monitors or using travel diaries to really see where people actually go in their day-to-day lives to think about what captures the neighborhood. And building a little bit more on what Marilyn was saying about these neighborhood spaces being a social determinant of health, we draw upon the RWJ Health Action Area 3 for the Culture of Health Action Framework. And this area really thinks about what are those factors in the communities that enable equitable access to healthy choices and healthy behaviors and healthy opportunities. And the action area includes 3 drivers: the built and physical environment, the social and economic environment, and the political and governance environment that supports healthy communities. So what do we mean by the built and physical environment? We're talking about things like sidewalks, walkability. What about bus stops? Are there places to rest at a bus stop? Are there shelters at the bus stops? What kind of public transportation systems are in place? What about traffic volume? How much traffic is there? Does it take a long time for someone to be able to cross a street because there's so many lanes of traffic? What about the amenities in those neighborhoods? Things like grocery stores or fast food or liquor stores. What about healthcare? How many pharmacies are there? Those are really important these days when we need to think about getting access to PPE like masks, as well as different treatments, as well as being able to get COVID vaccines. What about recreational opportunities, parks and gyms, but even things at a much bigger level like the climate? What about really having heat zones, being areas with lots of snow and air pollution and toxic industry exposures? But those are things that are more physical, but there are other things in the neighborhoods that affect us as well. And those are things in the social and economic environment, like poverty or socioeconomic disadvantage. We talk a lot about socioeconomic disadvantage or vulnerability, but the flip side is that there's another element of socioeconomic status, which is affluence, which is the resources that someone brings to the neighborhood, because there are a lot of people who have high education or high income. There's also indicators of racial residential segregation. How segregated is the neighborhood and what are the impacts for the residents who live there? Conversely, what's happening in terms of gentrification? How are neighborhoods changing over time? And is that shaping the health of the population? School quality is important, as well as housing affordability, arts and culture, crime, and even things like voter registration and turnout and political partisanship. What is it, how does that actually shape the behavior of people in the neighborhood, the resources that are available, and the amount of resources that can be drawn into that neighborhood because of those characteristics? Finally, things at the community and government level are things like ADA compliance. To what extent does the local area comply with the Americans with Disability Act and the transition plans? And cooling centers, what about those kinds of things? These are all kinds of things that people might be interested in looking at the neighborhood level. And the National Neighborhood Data Archive provides some resources, many resources, to be able to help you to dig into some of these questions and investigate them. So the National Neighborhood Data Archive, or NaNDA, as we call it for short, is a publicly available data archive that's in ICPSR. It contains measures of neighborhoods, or contextual measures as they're called, for locations across the entire United States. The measures that we create are not measures that are just replicating what's out there. We take existing data and we then make it user-friendly, and we often create measures that are theoretically derived. I'll tell you some more about that in a little bit. My justification and my motivation for creating this archive is that there was so much duplication and redundancy going on in research, where researchers were creating neighborhood measures for their particular projects. And then someone else across campus was creating the same measures for a different project. And nobody was sharing those measures. So there was a lot of redundancy and duplication of effort. So the NaNDA archive is really just depositing the measures that we have created in our research over time that are at the neighborhood level at different levels of spatial scale, that it can just be shared publicly. They're de-identified, they're not attached to any human records, they're not attached to individuals, they're just measures of neighborhoods. So anyone who's interested in addressing questions about place can download these data, and they can be linked with geographic identifiers, and I'll tell you more about that later too, with survey data or cohort data, or even electronic health records or medical claims data. Each NaNDA data set is actually represents a set of measures on a single topic of interest. They quantify different aspects of the environment, the physical, the demographic, the social environment. Our measures can be, some of our measures are just for 1 year, and other measures actually are longitudinal in that you can be using them to track changes in neighborhoods over time. Our data are generally tabular data, which means it's got rows and columns, but we also have data that's a shapefile, so raster files that can be used with ArcGIS and other geographic software. This is a quick summary of some of the kinds of topics that we have in NaNDA. In general, years that we cover right now are 2000 to 2020, but new measures are continually updating and being added regularly. We also have a lot of historic data going back to the 1990s that we have not yet made public, but that data is coming soon. We cover things about the demographic context of the neighborhood, land cover, parks, housing affordability, broadband, rural urban status. There are lots of different characteristics of neighborhoods that we capture. And again, this is based on our own research where we've used these measures as they relate to disability and cognitive function and a whole host of other health outcomes. Our measures, as I said, are theoretically derived. So for example, our measure of neighborhood socioeconomic status is based on a factor analysis of all census tracts in the United States. These data here are from the American Community Survey from 2013 to 2017. They're at the census tract level, and it's just the characteristics of those census tracts with respect to demographic characteristics. When we do a factor analysis of these items across the entire United States, we see that there's 3 separate constructs of socioeconomic status in the United States. There's neighborhood disadvantage, which is characterized by low income and poverty. But at the same time, there's this construct called neighborhood affluence, which is really characterized by people with a high proportion of people in that neighborhood that are in professional or managerial occupations, high proportion of people with college educated and higher incomes. So those are very different things. And in fact, they're orthogonal to each other. So they capture distinct aspects of neighborhoods. So affluence is not simply the absence of disadvantage. This is a very detailed summary. I'm going to take a couple of minutes to walk you through the different holdings that we have in NaNDA. You'll see that we have, on the left-hand side, there's different domains, and then the examples of the measures. The source data is where we get our raw data from, and then we change those data, we work with those data to make those data usable by others and make them more meaningful. In addition to the neighborhood disadvantage and affluence measures that I told you about on the previous slide, we have other measures of rural urban status, housing density, age structure, and racial residential segregation. In terms of neighborhood disamenities and amenities, we use data from the National Establishment Time Series database, which is a proprietary data source. And we have permission to create aggregate measures of these businesses at the census tract level to make them public. So we're able to release into NaNDA counts and per capita density of these things like libraries and religious institutions, bars and nightclubs and restaurants, grocery stores, dollar stores, so that we also have measures of post offices and laundromats and nail salons, and really just capturing all the different resources that are available to people living in different neighborhoods. This NETS data source also provides measures of healthcare, counts and per capita density of physicians and other healthcare providers, as well as pharmacies, and social services as well in terms of child daycare services and food banks. In terms of our school data, we have measures not only of school counts and district characteristics, but we also created a novel measure of the neighborhood school gap. This is a difference between the composition of the neighborhood and the composition of the school in that neighborhood with respect to racial composition, as well as with respect to poverty. This could be an interesting measure to use to capture potentially disinvestment in local neighborhoods or in local schools. We also have extensive measures of public infrastructure, broadband internet access, public transit stops, and in addition, we have traffic volume and street connectivity. We also capture, as I said, political partisanship, which is not only counts of voter registration and voter turnout, but measures about the histories of that census tract or that county for actually voting Republican or Democrat in going back to previous elections. In addition to the physical environment on climate and air pollution, we also have a very novel measure of housing air conditioning. So how many how many units, how many housing units in that census tract have air conditioning? That's becoming an increasingly important area of research to understand various health outcomes. The measures that we have in NaNDA are available at multiple levels of geography or spatial scale, as we say. This is sort of a diagram based on the standard hierarchy of geographic classifications. We have county data, which is mostly for our measures of weather and climate, but also for measures of political partisanship. We also have our school district measures related to the school characteristics. Most of our measures, though, are at the census tract or the zip code tabulation area. So the census tract is what is about 4,000 people per area. It's designed by the census to capture relatively homogeneous neighborhoods or spaces. These are typically available for linkages with secondary data, survey data, which release only the geocoded census tract identifier for participant addresses. And then you can use NaNDA to link via that census tract code to that survey data. For other data, such as claims data and also Medicare, Medicare claims data, typically if you are able to get the geographic identifier, it's at the zip code level. So that's the patient's zip code, residential zip code. A zip code is a postal delivery route. So it's not something that's a spatial area, but the US Census provides a crosswalk to link the zip code to the zip code tabulation area, or ZICTA. And then you can then link it with our zip code measures of neighborhood conditions in NaNDA. We also provide a crosswalk to the links to the crosswalk and instructions of how to do that linkage yourself. But I think what we're kind of picking up on is an important question that you really have to think about for neighborhood research, which is what size neighborhood is most relevant for your research question? So a lot of the work that I have done at the very small area is based on understanding the built environment for disability. So I'm interested in what makes it difficult for someone to be mobile in their community. If they have, for example, arthritis or lower extremity trouble in functioning, then really, do they have continuous sidewalks? Do they have a bus stop close by? Do they have crossings? Do they have a lot of traffic that they're going to have to negotiate? That means I want to know what's really right outside their front door, or at least very close to where they're living. So I choose mostly census block groups or census tracts. But if you're interested in something like climate or political partisanship, it's not really the census tract that you want, because there's going to be so much more impact of the resources that are available farther out. And the impact of the climate is not something that's very isolated to a particular location. It's more at a larger spatial scale. So for those kinds of questions, you do want to think about larger spatial scales like the county level, or even something like a zip code. This is a graphic illustration of the difference between the spatial areas that are captured by county on the left-hand panel and census tract on the right-hand panel. You can see that the county measures of neighborhood disadvantage, which is what's presented here, where the disadvantage, which the darker colors represent greater socioeconomic disadvantage. In Wayne County on the left, we can see that that's higher disadvantage. But if you look at how that breaks out by census tracts, there's a lot of heterogeneity in how neighborhood disadvantage is spatially distributed across Wayne County. So you're missing a lot of that nuance if you're just limiting yourself to working with county level data. Another example is county level broadband access. So a lot of the data that's available, that has been available on county level or on broadband internet access, is from data at the county level. So this data here is from the Microsoft anonymized data set that they collect. It shows areas across the United States. These are the counties. And if they're in blue, it means that they have less than 15% of the households in that county that have access to a decent minimum broadband speed. If we look up in Michigan here as an example, we can see that most of Michigan is actually apparently doing quite well in terms of broadband access, with a few counties being identified as not having decent broadband. But if you break that down at the census tract level, this is data that we have in NaNDA on broadband internet availability at census tracts. And I'm showing you here the results for Michigan itself. You can see that there's a lot of heterogeneity that's in the availability of broadband across census tracts. Again, the darker areas are the areas with greater broadband internet access, and the lighter areas are those without. You can see that most of the access tends to be down around the Ann Arbor, Detroit area, more urban area of the state. But if you dig a little bit deeper even into that area, you can also see that in fact, that internet access really is a ring around Detroit, and that in the city of Detroit itself, there are actually very much fewer fixed connections for high-speed internet. So understanding and being able to get these smaller area data points to capture neighborhood characteristics at a much smaller level than the county is important for understanding which people living in which neighborhoods are going to be having different health outcomes. I'm going to show you an example of some other research that's used NaNDA data to understand neighborhoods and health. These data are coming from our colleague Grace Noppert, who wasn't able to join us today. Grace is doing some important work thinking about how neighborhoods are related to COVID in terms of COVID burden and the consequences of COVID at the neighborhood level as well. So she's doing work in the COVID Neighborhood Project, or CONIP, which is trying to understand which neighborhoods might have been putting people at greatest risk for COVID in the pandemic, and how those high burden COVID neighborhoods might actually be at greater risk for social and economic shifts since the pandemic. So for example, high burden COVID neighborhoods might be at greater risk for a loss of population, but also a loss of businesses and just changes in the demographic structure. So she's interested in understanding what are those characteristics of neighborhoods that have shaped both risk of COVID, but also the fallout and the consequences of COVID for the social and economic characteristics of those neighborhoods. So here's an example of the kind of data that she's been using from NaNDA linked with COVID-19 case data, which is the prevalence of COVID cases at the census tract level through May 15th, 2021. These data she obtained from the public health departments across the United States. It's an ongoing effort to get these data and have them at the small area of the census tract. And you can see in the state of Louisiana over this time, there's a clustering of these COVID cases and the density of these cases with these red dots, more in these urban areas of the state. The larger the red dot, the more the cases, the greater the number of cases. These case counts are overlaid upon the census tract level measures of socioeconomic disadvantage, where the darker blue is greater disadvantage and the lighter blue is less disadvantage. So I'm going to show you the next slide, which actually zeroes in more on the city of New Orleans. And you can see here that the COVID case data through May 15, 2021, there are bigger dots. The red dots are bigger, more COVID cases in areas, in fact, with low disadvantage. The areas with higher disadvantage, the darker blue, in fact, actually have smaller red dots, so fewer COVID cases. Many people think that the neighborhood disadvantage, it was a risk factor for COVID, but the evolution of the pandemic and how it has evolved is very complicated. And she's doing some work to show that there really is no one size fits all for understanding how neighborhoods and the pandemic are related. So I'll let her go on with her work at some point, and you'll be able to hopefully hear from her another times. But in the meantime, why would you want to think about using NaNDA for your research question? I'll think about a few things and I'll tell you what I think. Ease of use. Most of our NaNDA measures have been made publicly available and are easy to download. You can identify the data that you want, the content, the data set, and then you can easily download it and link it at either the zip code or at the census tract level or the county level. Our measures are theoretically informed. We derive them to be for our research, so they are conceptually distinct and they are different from the source data that we get them from. We try to be thoughtful about creating measures that contribute and can be useful for others. But there's also interoperability across our measures. It means that if you download one data set, it's relatively easy for you to use another one of our NaNDA measures as well. And we also provide instructions in some of our code books for how you could actually combine different measures across the different data sets. So in summary, place matters. It matters to us because it's upstream to many individual factors. So it sets the context by which our health behaviors, our opportunities for employment, and our access to health promoting resources take place. You can use the contextual measures found in NaNDA to characterize a neighborhood's health landscape across a number of different characteristics and across a long time span. NaNDA data is most effective in combination with other geocoded data, so data from individuals from survey data or medical records, especially when it's geocoded at the census tract or the zip code level. So come check us out. Our NaNDA URL is here through our open ICPSR deposit. I would also like to note that we are actually now moving our NaNDA repository into a fully curated data set at ICPSR. It's not going to change anything. You'll still be able to find our fully curated data set through this link, but it will give you as a user greater capacity to search our data sets for particular measures and particular topics. So stay tuned for that coming up. In the meantime, I think that's it, and we can open up questions. For additional questions, if we're not able to get through all your questions now, there's the Health and Medical Care Archive. Please, you can contact that email down the road.
Great, thank you so much for this webinar. I will read the questions from the Q&A. So if you have any, please put them in there. And Marilyn and Philippa, you can answer as you see fit. So the first question is, given the smaller size of census tracts, are the NaNDA files confidential access or public use microdata files?
So our data are not restricted in any way. They are not counts of individuals. We use data, first of all, our characteristics of neighborhoods are often of things, not people. So there are things like the number of public transit stops in a neighborhood. So we don't have to worry about confidentiality of transit stops. When we do use people, they're coming from the American Community Survey or the US Census. We use the 5-year estimates of the American Community Survey for the recent years. And that's how, as you know, the confidentiality and the small numbers at small areas is taken into consideration. So we don't have any restrictions on what we release.
The next question says, I'm new to the US as a PhD student. Is this data accessible regardless of one's immigration status? Is there a restriction that requires one to be a citizen to access the data?
Absolutely not. Everybody is publicly available, fully publicly available. You can access all data. We do just require that when you do access it, you're required to just acknowledge that you won't use it for, I think that it's a standard ICPSR language that you're not to be using it for things that are not appropriate for, unless it's something not for research. But I think there's no restrictions on it at all.
The next question is, are there recommended methods, such as aerial weighting, to match NaNDA's census tract data to other neighborhood boundaries?
So that's a great question. And I think there's a lot to say about that, a lot of complex methods. Most of these methods are geospatial methods. We do this in our group, in our shop. We have a geospatial expert who uses ArcGIS to take census tract measures at the area and then create different boundaries around them by combining census tracts or changing the boundary of census tracts. It does involve, just manipulation of geographic data. I think there is another, if you go on our website, our NaNDA website, we do have a video by one of our technicians there that talks a little bit about that process of aggregating or changing the boundaries yourself based on the data.
The next question is, what do you find most exciting about this field of research right now?
Well, I can start, and then I'll pass it off to Marilyn as well to talk about it. What's most exciting, I think, right now is that I've done this kind of work for like over 20 years. And there was a time when the word neighborhood was a bad word and nobody liked this kind of research. I think there's much more recognition now and acceptance that where we live and what the places that we encounter actually matter and should be incorporated into research on health. So I think that's really exciting. I think at the same time, what's really fueling that is that there's so many more data sets that are available now and many more different sources of data to help us answer questions about what it is about those neighborhoods that are important for health. So I think that's really exciting. Marilyn, do you want to add something?
I'll just add that as somebody who, again, does this kind of research and uses these kinds of data, it's really, what I think is really great is there's different units of analysis there that are available to researchers, whether it's a county or a block or a ZICTA. I mean, we just have all this choice, which I think is wonderful. And you can have as much nuance or maybe less if that suits your research question better. I also love the fact that there's so much data here. There's so many measures that as a social determinants of health researcher, I've just never had access to this kind of data before. And I also really think it's valuable that it's longitudinal in many cases. It's not completely consistent, but to get longitudinal measures or measures over time is really so important. You're able just to answer a lot of research questions that you can't get, we couldn't answer previously.
I want to add to that a little bit, which is also, I think what's exciting that we're doing now is we're able to think about cumulative exposures to neighborhood. So not only where we live now, but where we have lived and how different points of the life course have exposed us to different contexts that can shape our health in different ways. And there may be critical periods of the life course, or periods of birth, or periods of when we transition to adulthood, we're particularly vulnerable to the context in which we're living. And I think there's the recognition and that these kind of data can help us to address that.
Great. The next question is, how often are the NaNDA data updated?
Great question. So the NaNDA data are updated in a number of different ways. First of all, we are constantly creating new measures with the data, the raw data that we have, and we go through a process of having them archived through ICPSR. And that takes a bit of a process and involves an updating procedure. But most of our updates take place when new source data become available. So for example, when the census releases we just got the 2020 ACS data, we can then move ahead and create new measures of neighborhood socioeconomic status. The NETS data is releasing a new set of data on businesses across the United States in 2022. So we'll be able to then update our measures and create new measures of the different features of neighborhood environments in terms of resources. I should also just point out when I'm saying that, one of the challenges of that, when we update things, they don't always stay the same. So we're finding in our neighborhood disadvantage measure, for example, we've had this measure, we've used it from the 1990s. It turns out that we don't see evidence of neighborhood disadvantage existing in the factor analysis in the United States with the 2020 ACS data. It appears that what's really driving the spatial distribution of socioeconomic status is a lack of affluence. So there's things that change, and that also creates some challenges for us as we try to update data.
This next question, I think, dovetails a little bit into what you were talking about, Philippa, but are you going to be expanding topics covered by NaNDA? Do you have any planned new measures?
Yes, we do. We do. Under this new funding that we have, we're actually going to be able to build out and create a lot of new measures. We're going to be doing, we're really interested in thinking about the consequences of COVID for neighborhoods and being able to identify which neighborhoods have changed with respect to business ownership, in terms of the racial distribution of business ownership, in terms of entrepreneurial failures in different neighborhoods. We're also going to be building out more of our segregation measures. Right now, they're currently not up on NaNDA as publicly available, but we are developing those for release. We are also very open and encourage people to contact us if they have any specific requests for types of neighborhood measures. We often have some measures that we've created that are not yet publicly archived, and we would be, we are moving to try and get as many of them up on Open ICPSR and ICPSR as we can. I'm trying to think what else that we're creating. We're really moving into creating a lot more climate measures, given the role of climate change and health. Those measures are actually motivated and driven by our co-investigator, Karina Grunland, who's an environmental epidemiologist. And we are looking at things like not only temperature and rain and snow, but also how much sunlight are in certain neighborhoods. What is the actual, sunlight exposure that someone has in their neighborhood? And I think that relates to things like mental health. Certainly in Michigan, we have a lot more cloud, so that can be a challenge as well. If I think of other things, I'm just having I have to go back over my notes and look at all the new things we're thinking about, but lots of new things.
We have another question about how people can see what's already published on the work that you've done, like using the NaNDA data.
I don't fully understand the question. Sorry, can you say it again?
How they can see what work has already been, like what research, I believe like Grace's work, what publications and research has already been done. Yeah.
That is exactly why we are moving NaNDA into ICPSR, not the Open ICPSR, because that will, I'm sure, Sarah, you can explain much better than I can, that will provide users with links to studies that have used the data.
Yeah, so once NaNDA is moved into ICPSR, there will be a bibliography. So when you're on a study page that is the NaNDA data, there will be a publications tab, and that will list all related citations that we find. And if you use it, we'll ask that you report your citation back to us so that it can be recorded there as well. And there will be as comprehensive of a list of publications as we can collect. If there's any other questions, you can pop them in the Q&A. You can also contact us at himca@umich.edu. And if the question is specific to Philip or Marilyn, I can forward it to them. If there is nothing else, I would like to thank our presenters today for bringing us this great webinar and encourage you all to continue exploring the NaNDA and HIMCA data available at ICPSR. Oh, we have a couple more questions coming in. So one question asks is there a place that they can specifically get the 1990s data?
We're really hoping to release that soon, actually, in ICPSR. And I was going to say, you can certainly keep tabs on the Open ICPSR site, and I'll try to make sure that there's a kind of notification that goes up to let people know when the 1990 data is coming out.
Great. Well, I do think that's all. Please send us any additional questions that come up throughout your day to himca@umich.edu. And otherwise, we will see you all on other resources. Thank you so much.
Thanks, Sarah.
Thank you.